of the participants for joining it. Hello, everybody. I'm Dr. Matthew Clark. I'm the Chief Medical Officer of the Alaska Area Native Health Service, and I'm the chair of the IHS National Pharmacy and Therapeutics Committee. I also serve as the operations team lead for the IHS National E3 vaccine strategy. And today I'm pleased to provide you with a brief clinical update regarding vaccines for the 2023-2024 fall and winter respiratory viral season, after which I'm looking forward to taking your questions. Next slide, please. My objectives today are to establish the role of vaccination as part of clinical and public health prevention efforts, to detail vaccines available for the 2023-2024 fall and winter respiratory viral season with a focus on COVID-19 vaccines, and then to review vaccine safety surveillance in the Indian Health Service. Next slide, please. Let me begin by acknowledging that vaccination is the clinical and public health prevention priority in the Indian Health Service. Announced last November, our IHS National E3 vaccine strategy is designed to ensure that every patient at every encounter will be offered every recommended vaccine when appropriate. This is inclusive of all ACIP recommended vaccines, including seasonal flu, COVID, and RSV vaccines as well. Details about the IHS National E3 vaccine strategy can be accessed on the IHS National Pharmacy and Therapeutics Committee website and include an easy one-touch access resource bank, as well as IHS best practices and information about becoming a designated E3 Champions pilot site. Next slide, please. September and October are the traditional beginning of the fall respiratory viral season for most geographic locations served by the Indian Health Service. Seasonal influenza accounts for an average of 12,000 to 52,000 deaths and over 200,000 hospitalizations annually in the United States. Meanwhile, respiratory syncytial virus, or RSV, is the leading cause of hospitalization among infants in the United States and also accounts for an average of 60,000 to 160,000 hospitalizations annually among persons ages 65 years and older. Finally, SARS-CoV-2, the virus that causes COVID-19, has been responsible for an excess mortality in the United States of over 1 million persons to date, and currently accounts for over 600 deaths per week. Next slide, please. Most serious infections resulting in hospitalization or death are preventable through vaccination. In fact, vaccination is the single best protection against serious infection or death from vaccine-preventable respiratory illness. Next slide, please. Many of you are familiar with previous strategies to combat COVID-19 with vaccination, beginning with the first COVID vaccine authorizations in late 2020. Following the end of the declared public health emergency, and as we move into the endemic phase of COVID, this year's approach to COVID vaccines marks a shift to an annual vaccination strategy. Earlier this year, vaccine experts directed formulation of a monovalent vaccine targeting the XBB 1.5 Omicron subvariant of SARS-CoV-2 for all vaccine platforms, including both of the mRNA vaccines and, pending approval and/or authorization, the Novavax adjuvanted protein subunit vaccine. Clinical evidence supports the effectiveness of the current 2023-2024 mRNA COVID vaccines against currently circulating strains, including both EG5 and BA.2.86. Next slide, please. Both the Pfizer and Moderna monovalent mRNA COVID vaccines were approved by the FDA earlier this month for individuals 12 years and older and authorized for emergency use in children beginning at age 6 months. As a result of this regulatory action, the bivalent mRNA COVID vaccines are no longer authorized for use. Following review by the Advisory Committee on Immunization Practices, the CDC has recommended monovalent COVID vaccinations for all persons ages 6 months and older, regardless of prior vaccination status. Next slide, please. Individuals 5 years of age and older, regardless of previous vaccination, are eligible to receive a single dose of an updated mRNA COVID-19 vaccine at least 2 months since the last dose of any COVID-19 vaccine. Individuals 6 months through 4 years of age who have been previously vaccinated against COVID-19 are eligible to receive 1 or 2 doses of an updated mRNA COVID-19 vaccine. Note that the timing and number of doses to administer for this group depends on the previous COVID-19 vaccine received. Unvaccinated individuals 6 months through 4 years of age are eligible to receive 3 doses of the updated authorized Pfizer-BioNTech COVID-19 vaccine or 2 doses of the updated authorized Moderna COVID-19 vaccine. Finally, people who are moderately or severely immunocompromised should or may receive additional doses of the monovalent vaccine, depending on prior vaccination status. Next slide, please. The mRNA COVID-19 vaccines now approved and authorized are supported by the FDA's evaluation of manufacturing data to support the change to the 2023-2024 formula. The updated mRNA vaccines are manufactured using a similar process as previous formulations. In studies that have been recently conducted, the extent of neutralization observed by the updated vaccines against currently circulating viral variants causing COVID-19, including both EG5 and BA286, appears to be of a similar magnitude to the extent of neutralization observed with prior versions of the vaccines. This suggests that the vaccines are a good match for protecting against the currently circulating COVID-19 variants. The benefit-risk profile of previously authorized and approved mRNA COVID-19 vaccines is well understood, as these vaccines have been administered to hundreds of millions of people in the United States over the last 3 years. Based on an evaluation of the evidence, the benefit-risk profile is deemed favorable for individuals 6 months of age and older to receive an updated COVID-19 mRNA vaccine. Although serious outcomes from COVID-19 are less common in younger individuals, they do occur. And it has been demonstrated that recently receiving a COVID-19 vaccine reduces the risk of such serious outcomes. Individuals who receive an updated mRNA COVID-19 vaccine may experience similar side effects as those reported by individuals who previously received mRNA COVID-19 vaccines. Mostly this includes local and systemic reactogenicity, such as injection site pain, fatigue, and muscle aches. Next slide, please. Contraindications and precautions include history of a severe allergic reaction, such as anaphylaxis, to a previous dose or component of the COVID-19 vaccine, history of a non-severe allergy to a component of the COVID-19 vaccine, or an immediate allergic reaction after administration of a previous dose of a COVID-19 vaccine, moderate or severe acute illness, history of multi-system inflammatory syndrome in children or adults, and history of myocarditis or pericarditis within 3 weeks after a dose of any COVID-19 vaccine. Next slide, please. Now switching gears. Seasonal influenza vaccine has been recommended for all persons 6 months of age or older for over a decade. A form of viral strain mutation known as antigenic drift requires yearly seasonal flu vaccination both to reduce the risk of infection and spread and to reduce the risk of serious infection, including hospitalization and death. The ideal time to receive influenza vaccination is September through October. So now is the most optimal time to encourage vaccination and to obtain one for ourselves. This year's approved quadrivalent vaccines cover 4 serotypes of influenza deemed most likely to pose risk during this season. This includes multiple vaccine manufacturers and formulations. While there is no preferential recommendation for most people, the ACIP did issue a preferential recommendation for people age 65 and older to receive a high-dose recombinant and/or adjuvanted flu vaccine. While flu vaccine effectiveness varies from year to year, the average reduction in hospitalization risk has been 42 to 82% in the last 10 years. Next slide, please. New in 2023 is the first ever availability of multiple RSV vaccines and immunization products, including the long-acting monoclonal antibody nirsevimab for infants and young children. Recently, the CDC's Advisory Committee on Immunization Practices recommended seasonal administration of the newly approved RSV vaccine Abrysvo for pregnant people to be given as a single dose between 32 and 36 weeks of gestation to protect the newborn from severe lower respiratory tract infection in the first weeks and months of life. 2 vaccines, RSV and Abrysvo, are both recommended for persons ages 60 years and older using a shared clinical decision-making approach based on risk for severe RSV disease, clinical judgment, patient preference, and the vaccine's safety profile. Next slide, please. From phase 3 clinical trials, efficacy analysis for RSV vaccines in persons ages 60 years and older showed that the vaccines were effective in preventing symptomatic, laboratory-confirmed RSV-associated lower respiratory tract disease during season 1, ranging from 82 to 88%, and during partial season 2, ranging from 56 to 78%. The CDC's Advisory Committee on Immunization Practices concluded that vaccination might prevent considerable morbidity from RSV disease. In terms of safety, the most common side effects were due to common local or systemic reactions resulting from the immune response to the vaccine. There were 6 cases of inflammatory neurologic events, including Guillain-Barré syndrome, acute demyelinating encephalomyelitis, and others. However, there was insufficient data to establish that the vaccines caused these events. Based on safety and vaccine effectiveness data, the ACIP recommended a shared clinical decision-making approach to RSV vaccines for persons ages 60 years and older. Next slide, please. More recently, the FDA approved and the CDC recommended maternal RSV vaccines during late pregnancy to reduce the risk of severe infant lower respiratory tract disease. Vaccine effectiveness was 91% within 90 days after birth and 76.5% within 180 days after birth. The most common reported side effects by pregnant vaccine recipients were injection site pain, headache, muscle pain, and nausea. There was an observed numerical imbalance in preterm births among vaccine recipients, though there was insufficient data to establish that these were caused by the vaccine. The ACIP considered the cost effectiveness and vaccine effectiveness of maternal RSV vaccines compared to the administration of nirsevimab for infants, and they ultimately recommended seasonal administration, typically September through January, of RSV vaccines to pregnant people between 32 and 36 weeks gestation. Next slide, please. Lastly, this past summer, the FDA approved and the CDC's Advisory Committee on Immunization Practices recommended nirsevimab, which is a new type of immunization, a long-acting monoclonal antibody, as a form of passive immunization against severe RSV disease in infants and young children. While it does not provide long-term protection to RSV disease, one dose lasts at least 5 months, which is the duration of the average RSV season. A single dose of nirsevimab was found in clinical studies to reduce the risk of severe RSV disease by about 80% when administered as a single dose during a given RSV season. The most common adverse reactions were injection site reaction and rash. Next slide, please. Previous studies have shown that RSV hospitalization rates are up to 4 to 10 times higher among Alaska Native and American Indian children under 24 months of age compared to the general population. The CDC's Advisory Committee on Immunization Practices has recommended that all infants younger than 8 months should receive nirsevimab regardless of race or ethnicity before the start of their first RSV season, and also that all American Indian and Alaska Native children ages 8 to 19 months should also receive nirsevimab shortly before the start of their second RSV season. Next slide, please. Given that this is the first year that we have vaccines available for COVID-19, seasonal influenza, and RSV, I want to emphasize that all 3 vaccines can be administered at the same time. They can also be safely administered with all other ACIP recommended vaccines without impacts on their safety or effectiveness. Co-administration of these vaccines avoids the opportunity costs which are associated with delaying recommended vaccinations. It is also important to note that there is a brief lag of up to a week or 2 until a vaccine recipient is afforded full protection from the vaccine. Next slide, please. I'll finish with a brief review of IHS vaccine safety surveillance. The CDC's Vaccine Adverse Event Reporting System is the gold standard for monitoring vaccine safety in the Indian Health Service. Since the incorporation of new IHS functionality in VAERS in September of 2020, the CDC has received over 3,000 vaccine safety reports originating from ITU facilities. While COVID vaccine safety comprises the majority of these reports, the IHS functionality that I'm going to describe is applicable to all ACIP recommended vaccines and is especially important with the rollout of new vaccine products. Next slide, please. The online process for reporting adverse vaccine events using VAERS is simple and available to anyone, including healthcare providers, other facility staff, parents, and patients. Next slide, please. The web link for VAERS reporting can be found on vaers.hhs.gov, after which the reporter can select the option to report an adverse event. This reporting is mandated for healthcare staff under certain circumstances, such as serious adverse vaccine events, including adverse events of special interest. The new Indian Health Service functionality involves entering the letters IHS in item number 26 of the report form, which permits identification of reports originating from the IHS system of care. The use of this IHS label in item 26 is advocated for all federal, tribal, and urban sites and also facilitates the analysis of adverse vaccine events in the IHS service population to allow for potential signal detection. Next slide, please. So in summary, we recommend offering every patient at every visit every recommended vaccine when appropriate. This is the first year that vaccination has been available for seasonal influenza, COVID-19, and RSV. Seasonal flu and COVID-19 vaccination is recommended for all people ages 6 months and older. RSV vaccination is available for persons over age 60 and pregnant women. Nirsevimab, a long-acting monoclonal antibody, is recommended for all infants under 8 months of age in their first RSV season, and all American Indian and Alaska Native children 8 to 19 months in their second RSV season. ACIP recommended vaccines are safe and effective and are the best defense against serious viral respiratory illness. It is important to report all serious adverse events using the IHS functionality to VAERS every time. Next slide. Thank you, and I would be happy to take any questions. And I'll turn my camera on here in case that's helpful.
All right. All right. Thank you all so much for your, I'm sorry, I can't see you all. I'm sorry, I can't see you all. Okay, so I just pull up my, I think I got lost. Okay, so one of the questions that I have here for you, Dr. Clark, to start us off is, if an infant or child has documented history of RSV, should they not get the RSV antibodies, monoclonal antibodies?
So that's a great question. And, some of the details about this can be found in the CDC's interim clinical considerations. What's important to note is that the passive immunity provided by nirsevimab is beneficial to infants under age 8 months in their first season, and also young children, American Indian Alaska Native children between 8 and 19 months in their second season. So it depends a little bit on the timing, but the nirsevimab itself would be safe in that setting.
If someone can only have the J&J COVID vaccine because of allergy of one of the components in the other vaccines, which booster would they get?
Okay, great question. So a couple of things. The so-called J&J or Janssen vaccine is not currently approved or authorized for use for COVID. It had been earlier in the vaccine campaign. And actually, in terms of monovalent vaccines, these new 2023, 2024 fall and winter vaccines with the XBB 1.5 Omicron subvariant formulation Currently, only the mRNA vaccines are available. That's the Pfizer vaccine and the Moderna vaccine. It is anticipated that an alternative vaccine, which is an adjuvanted protein subunit vaccine made by Novavax, will also be approved and or authorized in the near future. For those that have had a previous reaction to a COVID vaccine, what I generally recommend is that you consult with your medical provider to review the circumstances of the reaction and to determine if you're a candidate for the currently available vaccines or if you should wait for the Novavax protein subunit vaccine.
Can you clarify that only one dose is recommended for the COVID recommendation?
So I can clarify. So for all persons ages 5 years and older, with the exception of those who have moderate to severe immune compromise, so weakened immune systems, the recommendation is for a single dose of the monovalent 2023-2024 COVID vaccine. For those that are younger than age 5, and for those with moderate to severe immune compromise, there are recommendations that vary depending on the circumstances, such as whether or not you've been previously vaccinated, your age and so forth. For those folks, there are some alternatives that would allow for more than a single dose to be given. I would say that the term booster is now being jettisoned for COVID-19 vaccines as we move more to this annual vaccination strategy.
In the past, a primary series of COVID mRNA vaccine consisted of 2 injections, separated by a variable number of weeks. If I read the current recommendation, even previously unvaccinated patients over the age of 4 years will only receive 1 shot. Am I correct? And if so, why this change?
You are correct, and that's another great question. So again, people ages 5 years and older, regardless of previous vaccination status, the recommendation is for a single dose of the monovalent COVID vaccine. Currently, the 2 available ones are the mRNA vaccines made by Pfizer and Moderna. The reason for the change is that, unlike during the early stages of the COVID vaccine rollout and campaign, at this point, entering our 4th COVID year, most people have either been vaccinated and or had COVID. And so we're moving into a situation where there is some degree of pre-existing immunity. However, that does not provide full protection against serious illness, including hospitalization and death. And so for that reason, regardless of prior immunization status, vaccination with the new monovalent 2023-2024 COVID vaccine is recommended for everyone, 6 months and older.
Any idea when the updated Novavax vaccine will be authorized?
Well, I wish I had a crystal ball. What I understand is that it will be soon, but I cannot tell you exactly how soon. I would anticipate in the coming weeks, maybe a month or 2 at the latest.
So by the holidays, by Christmas.
Hopefully sooner than that. So what I can tell you is that when the ACIP met, they did review recommendations, which included the Novavax COVID-19 vaccine pending its regulatory approval by the FDA. I also know that Novavax has submitted a request to the FDA for regulatory approval. So we're just waiting on the FDA to take action. I don't think it'll be Christmas. I think it'll be sooner than that. But again, I don't have a crystal ball, and I don't have any inside knowledge to be able to tell you the exact date.
And he said, thank you for your responses to his questions.
Certainly.
Okay. The 3 of us are tag teaming them. Anyone else let me check in the chat box. I want to make sure I get that. Okay, here's a question from registration. Just gonna go ahead and tackle this one. Should people living with HIV and people living with AIDS receive the RSV vaccination earlier than the age of 65?
Okay, so that's a good question. Remember, there are three groups for whom there is a currently approved vaccine for RSV. The first group is infants and children, and the recommendation is for all infants under age 8 months in their first RSV season, regardless of any coexisting medical conditions, and inclusive of all American Indian and Alaska Native children in their second RSV season between the ages of 8 and 19 months, again, regardless of any coexisting medical condition. The second group are pregnant women in the third trimester of pregnancy, specifically between the gestational age of 32 and 36 weeks, again, regardless of coexisting medical problems. And then the final group where this may be an issue is for persons ages 60 and older. Remember that this is a shared clinical decision-making recommendation from the ACIP and the CDC. What that means is that for individuals ages 60 and older, they should sit down with their healthcare provider and have a conversation about their risk, not just age-based risk, but also risk associated with other conditions, including things like HIV. And then, based on those factors that I discussed earlier, make a decision in combination with their healthcare provider about whether to receive an RSV vaccine this year.
And just to touch on it again, because we want to make sure that everyone is on the same page, can you please explain one more time the difference between the Novavax and the Pfizer and Moderna?
Absolutely. So the Pfizer, I know it's confusing. The Pfizer and the Moderna vaccines are both based on the mRNA platform. The Novavax vaccine is a completely different type of platform, which is known as a protein subunit vaccine. For individuals who may have hypersensitivity to the mRNA vaccines, for instance, the Novavax vaccine, once it's approved and or authorized, would provide potentially a reasonable alternative for them.
Okay, checking my box again. Going back over here. How can facilities request updated COVID-19 at-home test kits that are not expired?
Another great question. So we talk about several things, several tools in our toolbox to prevent both the spread of COVID as well as serious infections from COVID. And those things include, we know that the single best defense is vaccination, but they still include things like masking when appropriate and testing when either you have been exposed to someone with COVID and or are symptomatic. Testing falls into several different categories, but the two main categories are laboratory testing that you receive on the order of a healthcare provider, and testing that you can perform at home, so at-home testing. Laboratory testing generally utilizes a technology called PCR, polymerase chain reaction. It's a bit more accurate than the at-home tests. At-home testing, which is a bit more convenient for folks, and is still reasonably accurate, particularly if the test is positive, utilizes a technology called rapid antigen testing. Rapid antigen tests have been approved now for quite some time during the COVID pandemic and are available through a variety of sources. So you can actually go down to your local grocery store or pharmacy and commonly find currently available at-home rapid antigen tests. If you are at an IHS facility, if you're a federal direct care facility, and or a travel facility that participates in the IHS pharmaceutical prime vendor, McKesson, you can order at-home tests through the National Supply Service Center, the IHS National Supply Service Center. And they do have the Abbott Binax Now at-home test currently available.
Checking my boxes. Okay. Oh, okay. Next question. Does IHS or CDC have strengths-based, community-centered resources for Native communities on RSV and the studies that led to the recommendations?
Another great question. So resources for patients and for communities about the new RSV vaccine. So a couple of things. Clinical resources and some patient and community-oriented resources regarding vaccines are currently available on the IHS E3 vaccine website. And that can be accessed at the link that I shared earlier. I think the slides are going to be going out, but you can just Google IHS MPTC and you'll be able to find that E3 strategy web page, and you'll be able to find vaccine-related resources there. Secondly, I will say that the RSV vaccines are the new kid on the block, across the board. And while there are some resources, such as a vaccine information statement on the CDC's website, and some resources on partner websites like the American Academy of Family Practice, these resources are still in development, largely because of the recent approval of these vaccines. So I would encourage people to look at the resources that are currently available, but also to keep your eyes peeled for new resources that are coming down the pipeline in the coming weeks and months.
Is the Nirsevimab given?
Nirsevimab.
I am.
Yes, it's an injection administered very similarly to other vaccines.
It's an injection. Okay. Oh, this is just a comment. Interesting that RSV has been around for so long, and we are just now getting a vaccine.
Absolutely. And we're not just getting one vaccine, we're getting really 3 vaccines for RSV. So RSV vaccination has been in development for quite some time because of the impact that it has both on children and elders. And we're very pleased to see that we now have multiple safe and effective options for the prevention of RSV, serious RSV disease in those high-risk groups.
Oh, okay. Another comment. I think it's really great. Her son is 23 and he got RSV twice. Well, that's not exciting, but he nearly died. It's exciting that he reached his Jordan year. But she just shared that her she has direct experience with her child having RSV twice. And
I
just
wish
this
I
little
wish we
niche
had access to RSV vaccines at that time. And I certainly appreciate that comment. I'm grateful for the fact that we do have something now to offer to parents of very young children, as well as to older people as well.
And just to put this little niche in here while we are talking about RSV, the next call that NIHB will be hosting is the week of October 15th for Infection Prevention Week. We will be collaborating with a partner to talk about RSV best practices for schools and child care centers. And NIHB is working to do some mobile clinics to be able to go out. So definitely, if you would like to partner with NIHB to come to your area, to your school, if you know that is a resource that would be useful in your community, please let us know in the evaluation so that I can follow up and we can see how we can support you all. But moving along, next question. Checking my check box in the Q&A. Okay, I had COVID on August the 26th with symptoms lasting until September 15th. When can I get the new COVID booster? And is there another crisis coming? it seems like many people I know have COVID.
I've noticed the same thing. So we did see an uptick in COVID infections and COVID hospitalizations beginning around the end of July, roughly, and lasting through early September. It's a little too early to say whether or not the recently observed downward trend in infections and hospitalizations over the last week or so will be sustained. But there's no doubt that that there was a mild to moderate increase in cases and hospitalizations during the late summer. That does not that and a recent history of COVID infection does not obviate the recommendation to get one of the new monovalent COVID vaccines. So, so long as you have recovered from your COVID-related illness, it is still recommended that you receive a monovalent vaccine, which can provide you with additional protection over and above the natural protection from the infection. You may recall during most of the COVID vaccination campaign, there had been some discussion about waiting up to 90 days after diagnosis of COVID before pursuing COVID vaccination. That was always an option, but still, it is recommended if you're 6 months or older, regardless of previous COVID status, provided that you're currently well from COVID disease, then you should in fact get one of the new monovalent COVID vaccines. And thank you for posting the IHS E3 vaccine strategy webpage in the chat there, Ms. Marzette. Really do encourage folks to check that out. We've had a great response from our tribal communities across Indian country to the E3 vaccine strategy. We've onboarded almost 36 pilot sites as E3 champions pilots. The application to become a pilot site is intentionally easy because we want to encourage people to undertake an effort and to innovate around vaccination. And so if you've not already done so, please take a look at that website. And if you are considering a project at your facility, it doesn't have to be a big project. If you or one of your teams at your site is interested in applying for that pilot project, I can tell you that we have been very generous in designating pilots from across our tribal communities in Indian country.
What are the statistics on the COVID-19 vaccine for decreasing severity to the virus?
So another great question. I'm going to pull up the safety and efficacy slide. What I can tell you is that we're talking about two different things here. So one is the risk of getting infected. The other is the risk of serious infection. Early in the COVID vaccination campaign, the primary goal, frankly, was to prevent the spread of infection. But as time has passed and as things have evolved, the primary goal now is to prevent serious infection, including hospitalization and death. And the new vaccines very effectively do that. I don't have the number to give you right in front of me, and I don't want to misquote the number, but I can tell you that the new monovalent vaccine is very effective at preventing serious infections such as hospitalization and death. It is probably less effective than previous versions of the vaccine early in the COVID vaccine campaign with preventing COVID infection and the spread of COVID. So our primary focus now is on preventing serious infection.
Can you provide Dr. Clark maybe some key messages that someone can take home today? What are some take-home key messages? What would be your top 5 messages for healthcare providers on this call that are having in-person meetings and community events, what are some take-home messages that they can say?
Well, first of all, I think the most important take-home message is that COVID vaccines, if we want to focus on that, are safe and effective, as are, frankly, influenza vaccines and RSV vaccines. So making sure that we're clear, studies have shown that if a healthcare provider or other healthcare staff member recommends vaccination, the likelihood of vaccine acceptance from the patient is much higher. And I would hope that our healthcare staff, in listening to presentations like this and others, and in informing themselves by reviewing the data themselves, would agree with me that these vaccines are safe and effective. So that's the most important take-home point. The second most important take-home point is that these vaccines, as we enter respiratory viral season, COVID, flu, and RSV vaccines for the appropriate age groups and individuals. So remember, for COVID and flu, that's everyone ages 6 months and older. For RSV, it's infants, young children, pregnant women in the third trimester, and a shared clinical decision-making approach for people aged 60 and older. But these vaccines are readily available, safe and effective, and should be offered. And we want to promote vaccine acceptance among those groups for whom they're recommended. The third take-home point that I would like to advocate is that, we experience both direct and indirect impacts from the COVID pandemic. One of the indirect impacts was the fact that general vaccination rates declined across the board. So not just for respiratory viral vaccines, but for all vaccines. And that's a serious problem because we rely on high vaccination coverage rates to protect us against things like measles and mumps and pertussis and a host of other vaccine preventable illnesses, especially for children and for older people. And so the other take-home point I would want people to take away from this presentation is the fact that we need to get into the mindset of offering every recommended vaccine to every patient at every visit when it's appropriate. And it's generally appropriate at every visit. The only time it's not appropriate is if there's a moderate to severe acute illness that someone's presenting with. And so we need to take a proactive approach to vaccination across the board, including respiratory vaccines. And then I guess the final take-home point I would want people to take away from this presentation is that we have the most robust vaccine safety surveillance system in the United States in our history. There are so many interlocking and overlapping vaccine surveillance programs in the United States, including in the IHS. So I mentioned the Vaccine Adverse Event Reporting System. There's also VSafe. There's a host of other national level vaccine safety surveillance systems. And we have found from surveillance of newer vaccines, like COVID, that they are safe. As we roll out newer vaccines like RSV vaccines, it's essential that if and when adverse vaccine events do occur, particularly if they're serious, then they should be recorded through VAERS. And if it's coming from our Indian Health Service system of care, we should be recording it with that IHS and item 26 so that we can look for safety signals, any early detection that's needed to identify safety signals early on. Do I expect those to happen? I don't actually, because I've been involved in the COVID vaccine safety surveillance as the team lead for the IHS Vaccine Task Force throughout the COVID vaccine rollout. And what we have found time and again is that these vaccines are safe, and they're safe for American Indian and Alaska Native people. So those would be my various take-home points. Oh, I did want to mention, so thank you, Ms. Marzette, for putting in the chat box the free at-home COVID-19 testing. I neglected that during my answer to the previous question. So you may or may not have seen that the Biden administration recently announced the most recent version of the opportunity for any American to order up to 4 free at-home COVID test kits. And you can literally just go to this link that Ms. Marzette has posted, put in your your name and your address, and shortly thereafter, the U.S. Postal Service will deliver up to 4 at-home COVID tests per household. This same investment included the purchase of at-home test kits for the Strategic National Stockpile.
Someone asked for the RSV vaccine prescribing information. I'm putting those PDFs up. I'm moving as fast as I can. I'm trying to monitor. I'm trying to work with you, Dr. Clark. As you say it, I'm trying to look for it.
You are doing great. I wish I had this type of technical support in every presentation.
And just to go back, I did see a question for me about the active love kits. I apologize if there has been a delay. NIHB have ran out of active love kits, so we are having we have reached out to order more supplies to make more kits to ship out. So if you have placed the order, give the comms team time. I just placed that order for us to re-up on our hand sanitizers, our disposable masks. In addition to the cloth masks, that you would now get a pack of disposable masks as well as an N95 mask. So just give us time. I promise I'm working on it. I'm trying to get it out before the end of October. So just give me a little bit more grace. But if you put in those Active Love kits, if you have not received a response, do not worry. Send me an email. I will not get mad. Y'all know how I am. Send me an email and keep sending me an email and text me. It's okay to text me. Text me, Dree, where's my Active Love kits? Send them. I want one box. It's okay. Stay up on me so that I can stay up on it. And so that when we get those products, we can make those boxes and get those out.
So
You have another question from Celeste. Do you see that? Is there a separate option for COVID at home kits than individual states are offering?
So the one that I just was talking about, which you put the link, I believe, in the chat box, it is a federal program, and it takes you, if you click on the link, it takes you straight to the U.S. Postal Service, and takes you like 10 to 15 seconds to enter your name and address, and then you get a tracking number shortly thereafter. I recently did that myself. I'm not familiar with the state-specific or any state-specific program, and that may be because it's not pertinent to my state, but it's possible that I'm ignorant of that. So I apologize for lack of knowledge about any state programs that are offering at-home test kits. So I do see in the chat that state of Minnesota and Wisconsin are offering free at-home test kits. So thank you for mentioning that. That's a great program. I do also see a question about the safety sheet for monoclonal antibodies. I think you're talking about the vaccine information sheet, and that is available. I will defer, I think, to Ms. Marzette to put that in the chat box. But if you don't access that, you can also go onto the CDC's website and just do a quick search on that, and it should pull it up. I also wanted to mention, recently we've had questions about the availability of these various vaccines. So there are many different ways to access vaccines. We've kind of moved away from the process that existed during the COVID pandemic, at least for COVID vaccines. So if you go to an IHS facility, you should be able to receive your vaccine at no cost, regardless of your resources, if you're an eligible beneficiary. Vaccines for children includes COVID vaccines for everyone up to their 19th birthday at no cost. And that's the typical resource for COVID vaccines for those younger folks in our service population. The Bridge Access Program, which is being operated by the CDC, is new this year and will last through the end of next year. And it offers free COVID vaccines for adults who don't have another resource and who are indigent. It does require the provider to enroll in the Bridge Access Program. So if you go to an enrolled provider and if you meet those criteria, then you can get your vaccine that way. For those that are seeking to order adult COVID vaccines through the IHS Pharmaceutical Prime Vendor, if you participate in that, or if you want to participate in that, those vaccines are now available. So both the Pfizer and the Moderna mRNA COVID vaccines are available for ordering and should deliver to most sites within 1 to 3 days. They are refrigerated, so over the weekend, sometimes it takes a little bit longer. But if you get your orders in earlier in the week, you should get them that same week. The RSV and the Abrisvo, the vaccines for both pregnant women and for persons ages 60 and older, are also now available through the Pharmacy Prime Vendor and other resources. And for those who get their vaccines outside the IHS system of care, vaccines for flu, for COVID, and for RSV should now be pretty readily available through most commercial retail outlets as well. COVID vaccines, if you have insurance and you go to outside the IHS system, should be covered by your insurance plan because of requirements of the Affordable Care Act. And then some of the newer vaccines should be onboarded to that program with the next season. So in addition to which, we anticipate ample supply of these vaccines. So there should not be a shortage for those that are eligible and want to be vaccinated. And we hope that that's everyone who's eligible. I know we're at the top of the hour, Ms. Marzette. I'll turn things back over to you. I really appreciate this opportunity to provide with some information to this group, to respond to your excellent questions. I hope it's been helpful to you. I look forward to future opportunities. And please don't hesitate to reach out to me if you have questions about anything from the presentation today or other questions such as those related to the IHSE3 vaccine strategy. And again, thank you all so much, and I hope you have a great day.
And I will include all of your questions from the fact sheets, all of the vaccine, emergency use authorization, EUAs, the fact sheets. I will include all of those on the last slide of Dr. Clark's presentation. All questions from the chat box will be included on the last slides of the presentation with this answer. A Q&A sheet would be developed with all of your questions from the registration. Please give CDC time to respond to all of those so that I can send them as one document. A survey will go out. In that survey, you will have the opportunity to let NIHB know if you need more PPE for your tribal healthcare facilities. We will also be I will acknowledge the act of love kits. I have already sent a teams to our team to let them know that we are having more requests coming in. So do not be afraid to email me if you need more act of love kits. Miss Lena, I am going to follow up with you. That was someone else in the chat box. I am also going to follow up with you post webinar. But anyone else, if anyone needs support, we're hosting any vaccine clinics this fall, please let us know, because NIHB want to be in the community. We want to support you all. We thank you for all of the hard work, and we also just want to make sure that we are prepared to combat all the respiratory illnesses that's going to be flying around this fall and winter. And the recording will be shared. So I will be sharing the recording, the slides, the questions, the fact sheets, link to where you can order up-to-date at-home kits. All of those things will be shared with you all following this webinar in the slides, and I will also have additional links. So other than that, next month the call will be on RSV and how we can make sure that our babies and our mothers are safe and protected. Thank you all. Enjoy your evening, your afternoon, and I will talk to you all online.